Hello, welcome to Enfoque en Exclusivos de Medicina Interna. My name is Marina Zuleta. I'm in 8th semester of medicine, and today I'm going to introduce the topic of clinical differences between COPD and asthma in adult patients. So first of all, we're going to describe each pathology. So COPD is a pathology process characterized by an airflow limitation that is not completely reversible. This airflow limitation is generally progressive and is associated with abnormal pulmonary inflammatory response. We have a chronic bronchitis and emphysema. In asthma, asthma is an inflammatory disease of the airway in which chronic process occurs and there before an increase in the reactivity of the airway and recurrent episode of wheezing, respiratory difficulty, intercostal indrawing, cough, and chest tightness, especially in the night and in the morning. We have some things in common, like both pathologies have high prevalence, both are an important reason of consultation, both the definition are not clear, both are chronic disease, they have similarity of pharmacologic treatment, like the use of highlighted route of pharmacologic administration, and some patients have both pathologies. Now the differences, first we have the epidemiologic differences. Asthma is more common in pediatric population, but COPD is more prevalent among people over the 70 years of age, and this increases as the age increases. We have the risk factors. The smoking is the most important risk factor for COPD, but not all the smokers develop the disease. Asthma, unlike COPD, has shown a predisposition to have an atopy. Now the inflammatory differences. Inflammation in asthma is characterized by being eosinophilic, directed by Th2 lymphocytes. This inflammation affects all the airway and does not involve the lung parenchyma. And a characteristic lesion produced by eosinophil is generated, which is the building of the airway epithelium. In the contrary, COPD have a neutrophilic inflammation. There is clear increase inactivity macrophages in the lung parenchyma, and the predominant lymphocytes are the CD8 type and not the CD4 type like in asthma. In the inflammatory mediators, in asthma, the predominant cytokines are the interleukins IL-4 and IL-5, which are essential for synthesis of IgA, and the activation of eosinophils and the mast cells, while in COPD, it's IL-8, which is selective for neutrophil chemotaxis. The response of the treatment is different between asthma and COPD, cause the inflammation that characterizes asthma is notably suppressed by corticosteroids, which inhibits all the phases or aspects of inflammation. However, corticosteroids have a limited role in treatment of COPD. Now, in the lung function study, this spirometric study for the diagnosis of COPD, it's essential, while for asthma, it's just simply useful, which it's respect the prognosis of COPD. It's considered a reference parameter, but in asthma, it's just like a little bit. And the bronchodilator test. In asthmatics, the reversibility of bronchial obstruction with bronchodilators are anti-inflammatory treatment. It's complete or almost complete, but this is not the case for COPD. And we have the test of bronchial hyperreactivity present in COPD, and its presence as a poor prognosis. And in asthma, it serves together with the clinic for the diagnosis, especially when the spirometric and the bronchodilator tests are negative. Now, in the treatment in asthma, the current treatment for asthma is based on both general and specific prevention measures and the use of two groups of medication like bronchodilators, short action as a rescue and long action as a background treatment, and anti-inflammatories like corticosteroids and anti-leukotrienes. In COPD, the bronchodilators have shown a small increase in FEV1 over the baseline value, about the 10%, and can improve symptoms by reducing hyperinflation. In particular, ipratropium bromide is the first-line drug of the treatment of COPD, since it exerts its action on the entire bronchial tract. It had the same effect as beta-adrenergic, but with the less risk of decreasing the oxygen pressure, and practically don't have like side effects. On the contrary, COPD, corticosteroids do not suppress the inflammation even at high doses, possibly because they prolong the life of the neutrophil. These are my references, and if you like the video and found interesting, don't forget to subscribe and like it. Thank you very much.